Hello everyone, so this is a recorded lecture for the pathology of the cardiovascular system. So before we proceed with the pathologies, let us have a short introduction about the cardiovascular system. So the heart acts as a pump to propel the blood throughout the body via the circulatory vessels. So I have a question for you. Does the four chambers of the heart can be clearly demonstrated on conventional chest PA? What do you think? The answer is no, because the heart lies in an oblique plane within the mediastinum. Another question for you. For the evaluation of the heart, what chest X-ray projection could be used and why? Is it AP or PA? The answer is chest PA. So to minimize the magnification of the heart, that could be a misinterpretation for the heart size, and because the heart lies anteriorly to the chest, so it places the heart closest to the image receptor, therefore it will reduce the magnification. So for the frontal projection, the cardiac silhouette. So 2/3 of the heart is lying to the left of the midline, and the right side is composed mainly of the right atrium, and the left side is composed mainly of the left ventricle. So why do you think is it necessary to have a lateral projection of the heart? It is because the right ventricle lays midline within the cardiac shadow, and it is located anterior to the right atrium and left ventricle, while the left atrium lies on the most posterior aspect of the heart. So the PA and lateral projections of the chest can be used to demonstrate the four chambers of the heart. So now let us proceed with the pathologies of the cardiovascular system. First is the congenital and hereditary disease. So fetal circulation and blood gas exchange occur within the placenta. There are certain characteristics that are present in the fetal circulatory system that should normally disappear at birth. First is the foramen ovale. It is the opening in the septum between the atria that allows the blood to bypass pulmonary circulatory system. Second is the ductus arteriosus, which connects the pulmonary artery and descending aorta. So there are times that these two characteristics failed to disappear. The etiology could be inherited genetic disorder or chromosomal aberrations such as Down syndrome, or environmental factors such as drugs, alcohol, infection, radiation, and maternal disease. So the imaging modalities and assessments that plays a critical role in the diagnosis and treatment of congenital anomalies are radiography and ultrasound, physical examination to diagnose heart murmurs. So when we say heart murmurs, it is the abnormal heart sound resulting from disturbed or turbulent flow, often through malformed valves. And last is ECG. So say ECG, the abnormal heart rates and ventricular hypertrophy can be seen. So what are the modalities that are used for the continuous evaluation of congenital heart diseases? So these are the MRI and the CT scan. So the common signs of a heart failure includes tachycardia. It is where the heart rate is over 100 beats per minute, because the normal heart rate in children is 70 to 100 beats per minute. As for adult, it should be 60 to 100 bpm. So the counterpart for tachycardia is the bradycardia. Bradycardia is lower than 60 beats per minute. So it means that it doesn't pump enough oxygen-rich blood to the body. Another sign of heart failure is respiratory distress. Another is cyanosis and weak or impalpable pulse. So now we have here a patent ductus arteriosus. So when we say patent, it means open or failing to close. So the ductus arteriosus is a temporary vessel that is used during in utero life. So this condition is more common in premature infants, which is born before 28 weeks of gestation, especially in those with respiratory distress syndrome. So infants with this condition generally have a heart murmur and display cyanotic features resulting from the shunting. So echocardiography is the imaging method of choice for evaluation of severity, while color Doppler technology demonstrates the reverse pulmonary artery flow during diastole and shows the full length of the ductus arteriosus. Chest radiography is used to show cardiomegaly with prominence of the left side of the heart and ascending aorta and increased pulmonary vascular congestion. When we say cardiomegaly, it is the enlargement of the heart. We measure this through cardiothoracic ratio. It is measured on chest X-ray, PA projection. It is the ratio of maximal horizontal cardiac diameter to maximal horizontal thoracic diameter. A normal measurement is 0.42 to 0.50. If the measurement is less than 0.42, it is pathologic, while if it is greater than 0.5, it is considered as cardiomegaly. So the treatment for patent ductus arteriosus includes fluid restriction and diuresis, use of drugs, and surgical intervention. It is the last resort and it is not performed until 1 to 2 years old of the child. Next is the coarctation of the aorta. It is the narrowing of the aorta and may occur at the junction site. So it occurs anatomically inferiorly to the vessels responsible for circulation to the head, neck, and upper extremities, so the circulation is not affected. The narrowing of aorta may occur at the junction site of ductus arteriosus. The blood flow to the abdomen and lower extremities is compromised and femoral pulse is very weak. This may lead to heart failure. The treatment for coarctation of the aorta is surgically by removing the narrowed region of the aorta and reattaching the normal aorta superiorly and inferiorly to the coarctation. Two bulges of aorta are radiographically demonstrated beside the stenosis. A rib notching can also occur. It is a well-defined bone erosions along the lower rib margins as a result of the enlargement of anastomotic vessels. Next is septal defect. It is a defect in either the ventricular septum, it divides the left and right ventricles, or the atrial septum that divides the left and right atrium, allows the blood to be shunted between the two chambers and mixing pulmonary and systemic blood. So, the blood is generally shunted from the left chamber to the right chamber because of increased pressure on the left side of the heart. So this results into the enlargement of the right side of the heart and increased pulmonary vascularity as the lungs overload with blood. So we have two atrial septal defects and ventricular septal defects. The atrial septal defect is the most common congenital heart defect. It is a failure of causing of foramen ovale. So this is detected clinically by an audible heart murmur at the left sternal border around the age of 1, as well as by atrial dysrhythmias on ECG evaluation. So radiographically, the right atrium and ventrically are enlarged, resulting in cardiomegaly. While the ventricular septal defects, it is more serious because of the pressure difference is greater. So audible murmur is a little lower on the left sternal border. A Doppler echocardiography is the imaging method of choice for both defects. Next is transposition of the great vessels. The aorta arises from the right ventricle instead of the left ventricle, and the pulmonary trunk arises from the left ventricle instead of the right ventricle. So what happens is that the deoxygenated blood returns to the right atrium, travels through the right ventricle, and is pumped through the aorta back into the systemic subsystem without being oxygenated. The oxygenated blood returns to the left atrium, travels through the left ventricle, and is pumped through the pulmonary trunk back to the lungs for gas exchange to occur. A conventional radiography is used to determine narrow mediastinum because the vessels are superimposed and the main pulmonary trunk is not in the usual location. So the pulmonary congestion is also visible through the conventional radiography. An emergency cardiac catheterization and balloon septostomy is used to enlarge the opening between the atria to increase mixing of venous and arterial blood and to decompress the left atrium. Next is the tetralogy of Fallot. So this is a combination of the four defects. So first is the pulmonary stenosis. So this prevents passage of sufficient volume of blood from the right ventricle to the lungs and results in the most common cause of cyanosis in infants with CV anomalies. Next is the ventral septal defect and the overriding aorta. So normally the aorta should arise from the left ventricle, but the aorta rises from the ventricular septal defect and it overrides the right ventricle that results into hypertrophy. So this makes the boot-shaped cardiac shadow as the displacement of the heart apex. And last is the hypertrophy of the right ventricle. Next is the valvular disease. So abnormalities of the heart valve's cardiac symptoms are dyspnea, fatigue, syncope, chest pain, and the sign is murmurs. So there are lesion of valves and it is usually an abnormal pulses detectable through palpation. The rheumatic fever is the most common cause of chronic valve disease of heart. It most frequently affects the bicuspid or the mitral valve and aortic valves. It is more common in women and it produces inflammatory changes within the connective tissues. It may also result in stenosis, insufficiency, or incompetency. A rheumatic fever has an audible distinct heart murmur. Another valvular disease is the valvular stenosis, and it is caused by the scarring of valve cusps that eventually adhere to one another. Mitral valve stenosis inhibits blood flow from the left atrium to the left ventricle. So this slows the blood flow through the lungs and right side of the heart that results to the enlargement of the right side and left atrium. Damaged valves are often replaced surgically, especially in patients experiencing symptoms of heart failure. Next is a congestive heart failure. So this occurs when the heart is unable to propel blood at a sufficient rate and volume. This is most commonly caused by hypertension, overburden the heart. It may develop gradually or have a quick onset in combination with pulmonary edema. So this results in congestion of the circulatory systems and does not allow a sufficient supply of blood to reach the tissues of the blood. CHF may affect either side of the heart, but both sides are commonly affected together. A left-sided failure is when the left ventricle of the heart cannot pump an amount of blood equal to the venous return in the right ventricle. The pulmonary circulatory system becomes overloaded. So the physical examination, it is often manifested by increased heart rate because the heart tries to compensate for the deficiency. So the signs and symptoms are difficulty of breathing, shortness of breath on exertion, and for severe is respiratory distress syndrome. They are awakened at night. So sleeping and recumbent is impossible. So the most common cause for left-sided failure is hypertension. Your right ventricular failure is not as common as left-sided failure and occurs when the right ventricle cannot pump as much blood as it receives from the right atrium. So this causes the venous blood flow to slow down, producing engorgement of the superior and inferior vena cava and edema of lower extremities. A common complaint from individuals with right-sided failure is swelling of the ankles. So the common causes are the pulmonary valve stenosis, emphysema, pulmonary hypertension secondary to pulmonary emboli. So radiographically, it is seen as an enlargement of the right atrium and right ventricle. Cor pulmonale results from a lung disorder producing hypertension in the pulmonary artery and an enlargement of the right ventricle. As for the acute, it's from pulmonary embolism, and for chronic, it's from COPD. It results from alveolar hypoxia and common symptoms include dyspnea and syncope. Patient may also experience chest pain. The chest X-ray reveals enlargement of the right ventricle and proximal pulmonary artery. It may result to venous thrombosis and may be placed on a long-term anticoagulant. As for our degenerative diseases, we have atherosclerosis. It is the hardening of the arteries. It may occur in any artery, but it has a predilection for the aorta, coronary arteries, and cerebral arteries. The risk factors that could not be controlled is increased age and family history. And the risk factors that can be altered is the serum low-density lipoprotein, reduced levels of HDL, hypertension, cigarette smoking, obesity, and sedentary lifestyle. So atheroma formations are composed of intracellular and extracellular lipids, muscle, and connective tissue. Next is the coronary artery disease. It results from the deposition of atheromas in the arteries supplying blood to the heart muscle. Major complications include angina pectoris, MI or the myocardial infarction, and subsequent myocardial necrosis. The risk factors includes tobacco use, diets high in fats and calories, and low in phytochemicals and fiber, and poor physical fitness. Medical treatments for this condition is the use of anti-anginal drugs to improve circulation and decrease the amount of oxygen consumed by the myocardium. Surgical treatments are coronary artery bypass grafting, in which it involves bypassing the obstruction with a segment of saphenous vein, and the NUCMED is used for myocardial perfusion scans and gated examination to determine the presence of CAD. Myocardial infarction is most commonly caused by an acute thrombus of the coronary arteries and primarily affects the left ventricle of the heart. The patient may experience a sudden onset of severe crushing chest pain that may radiate down to the left arm or up into the neck. They may also feel a profuse sweating, shortness of breath, nausea, or vomiting. A milder symptom could be indigestion. The percutaneous transluminal coronary angioplasty with stent placement is routinely performed to open stenotic vessels. Treatment for MI is thrombolytic therapy. It includes streptokinase, anistreptase, alteplase, and retaplase. If the therapy is started within 3 hours, chances of survival are better. Next is aneurysm, a localized ballooning or outpouching of a vessel wall. So this results when the vessel wall has been weakened by atherosclerotic disease, trauma, infection, or congenital defects. This has 3 types. First is a saccular aneurysm. It is a localized bulge involving one side of the arterial wall, and it occurs in a cerebral artery. Next is a fusiform aneurysm. It includes bulging of the entire circumference of the vessel wall, and it is usually seen in distal abdominal aorta. Last is the dissecting aneurysm. It results when the intima tears and allows blood to flow within the vessel wall, thus forming an intramural hematoma. The symptoms of these are often mimic those of a heart attack. An abdominal aortic aneurysm is usually seen using a cross-table lateral abdominal radiograph. It is visualized as an enlargement of aorta and calcification of vessel wall. Diagnostic ultrasound, MRI, and CT scan is used to determine the size and extent of the aneurysm. A thoracic aortic aneurysm is a congenital anomaly or blunt chest trauma, while CT, MRI, and transesophageal ultrasound assess the size and extent of the aneurysm. Venous thrombosis is the formation of blood clots within a vein. These clots commonly form in the veins of the lower extremities, so it results to slowing of blood return to the heart. The contraction of leg muscles assists with venous blood return. Therefore, to prevent venous thrombosis for the post-operative or bypass patients, it is important to place them in prone position. Thrombus formation generally begins in the valves of the deep calf veins, where thromboplastin traps RBC to create blood clot. So sonography is used to determine location and extent of this venous thrombosis. A phlebitis is an inflammation of the vein, and it is often associated with venous thrombosis. Last is the pulmonary emboli. So it occurs when a blood clot forms or becomes lodged in a pulmonary artery. So the symptoms are a sudden onset of coughing, acute shortness of breath, and chest pain. So the treatment for pulmonary emboli includes thrombolytic agents such as streptokinase, urokinase, or tissue plasminogen activator, or placement of inferior vena cava filters. So the computed tomographic angiogram demonstrating a large pulmonary embolism in the right pulmonary artery is shown on the picture. And these are the pathologies of the cardiovascular system, and I hope that you guys have learned something from this recorded lecture. If there are certain parts that you find it confusing, just leave me a message and I am willing to enlighten you with those confusion. So thank you so much.